Morning. 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 I'm Dr. Brian Mustanski. I'm the director of the Impact Program, which is one of the organizations that's co-organizing this conference today with the Center on Halsted. And it's my pleasure to welcome you here to Northwestern today for our LGBT Health and Wellness Conference, our second annual LGBT Health and Wellness Conference. I want to start out asking, is there anyone in the room who's not from Chicago? Raise your hand. Anyone from outside of Illinois? All right, who's from the furthest away? You know, last year we were surprised to get some people from the East Coast, and if you think you're from the furthest away, shout out where you're from. West Coast, California, like California? Yeah. Anyone from further away than California? I guess that makes you international. Yeah? Ireland. All right, great. Wow, that's exciting. So this is now the International LGBT Health. Let me just start by saying a little bit about the Impact Program here at Northwestern, in case you're not familiar with our program. So we're based in the Department of Medical Social Sciences, which is a department that's now about 4 years old, and it's a home for interdisciplinary social scientists doing research on health and biomedical aspects of health. The Impact Program has a mission to conduct translational research that improves the health of the LGBT community, and we primarily do that through research projects that are funded by the NIH, the CDC, the Chicago Department of Public Health, and various foundations. And by translational, that means that we're really trying to conduct research that moves on that spectrum from basic studies of epidemiology, identifying the prevalence of various health issues, to longitudinal studies that help us understand mechanisms of health and disease, things that put young people at risk or prevent the development of health issues, through the development of interventions that sort of respond to that information that we've collected to change and prevent health issues from developing, and then working with community organizations to take those interventions and put them into practice. So that's really our model of translational research, is moving things from basic research into application as rapidly as we can. And one of the ways that we do that is by partnering with community organizations. And our primary partner is the Center on Halsted. We're a resident research partner of the Center on Halsted, which means that Northwestern has space at the Center on Halsted. We are there, we have staff who are there every day. We do a lot of our research studies embedded within the community. We benefit from their experience. What they're learning informs our science. Our science ideally informs the work that they're doing, and we have this lovely cyclical relationship where we're learning from each other all the time. It's really fantastic. And the last thing that we do at the Impact Program is to really focus on training the next generation of LGBT scholars. And we do that through training interns, undergraduates, graduate students, postdocs, junior faculty members, and also through events like this where we really try to bring together people from the Chicago and now international community to come together and really share ideas, work together to address some of these disparities that are experienced by our community. I just want to sort of mention a couple of the activities that we have going on at the Impact Program. One of them that we're very excited about, which is funded in partnership with several departments at Northwestern, psychiatry, infectious disease, as well as the Center on Halsted, is one of the first federally funded training programs in LGBT health. And so we were very fortunate in the last year to receive a grant from HRSA to develop a training program for psychology residents in LGBT health. It's the first of its kind, and we're very proud of it. It's been one of our big accomplishments, and I think really reflects the benefits of sort of coming together with interdisciplinary collaborators, community organizations, to help train and conduct research. A couple other things that you can be looking forward to in the coming year that are from Impact is we're editing 2 special issues of different journals. So we're editing a special issue of American Journal of Public Health that's going to be coming out in February, focused on the health of LGBT youth. And so there's a whole series of papers in that issue, co-authored by collaborators from around the country. And in partnership with the Fenway Institute in Boston, we've created this special issue, and it really focuses on a variety of different health issues facing LGBT youth. So that should be coming out in February. And this month, we're co-editing a special issue of Archives of Sexual Behavior focused on the health of male couples and sexual health aspects of male couple relationships. And there's a lot of really fantastic papers in that issue focusing on methodology and findings related to sexual health in male relationships. So things to check out. One of the other things I just want to comment on today is a couple of people have asked me how I was able to arrange to have the governor sign the gay marriage bill today. And so, it's just another example of the influence that I have at all levels of government. We couldn't obviously start without commenting on the fantastic news that Illinois this year in June will become the 16th state to allow gay marriage. We were supposed to be the 15th state, but Hawaii sort of leaped ahead of us. So I think that's and we will be watching the signing this afternoon. We're going to be streaming it here, so everyone's welcome to come back into this room, and we'll be able to watch the governor sign the bill, assuming that it happens on time. If not, we'll have to spitball it a little bit. But I think that is an example of sort of why we need research on LGBT health. The social status of LGBT people is changing so quickly. Things like same-sex marriage, which didn't exist a decade ago, are really changing the types of relationships, the legal recognition of relationships, and we know that has impact on health, and we need to understand those processes. Another thing that's occurring today is Transgender Day of Remembrance, which is a day that gives members of the transgender community and their allies a chance to step forward and stand individual, memorializing those who died due to anti-transgender violence. This year alone, there are 70 known anti-transgender murders that occurred, and domestically we know that half of anti-LGBT murders that occur amongst transgender people. So these are two examples of the spectrum of what we're experiencing as LGBT people in society. The exciting advancement in some ways around having same-sex marriage, but at the same time, the tremendous hate and victimization that can be experienced by the most vulnerable members of our community. And I think, again, that's something that we need to be keeping in our minds as we think about the need for this kind of work. Let me say thank you to the tremendous team at the Impact Program and the Center on Halsted for putting this conference together. At Impact, Dr. George Green and Julia Dudek, our faculty, postdocs, and staff who reviewed abstracts, who organized the event, worked with the tremendous team here at Northwestern Memorial Hospital to get everything organized. So thank you to them. And also our collaborators at the Center on Halsted, Dr. Claudia Mosier, Dr. Rachel Gershon-Gates, Julie Walters, the staff and volunteers at COH who've really been a fantastic partner with us. So thank you to them. I also want to thank our 18 co-sponsors for the conference today, which I am just so excited to report that we have 18 co-sponsors. I think that undoubtedly this kind of event could not take place without their support in terms of spreading the word, the financial support, the organizational support. It's just been really critical to make this event happen. On top of that, I think it really speaks, having this many organizations throughout the Chicago area really speaks to the draw that LGBT health has across the city of Chicago with so many different organizations and the potential for us to work together to address some of the needs that our community has in the city of Chicago and beyond. I want to specifically mention our platinum sponsors, Northwestern Memorial Hospital and the Northwestern Memorial Feinberg School of Medicine, Institute for Public Health and Medicine, and also our gold sponsors, the Adler School of Professional Psychology and Howard Brown Health Center. And all of the other fantastic silver and bronze sponsors who are on the screen and listed in your program, I just want to give a tremendous thank you to all of them for making this conference possible. One other thing that I want to mention before I go is that on December 2nd, we will be having a symposium also here at Northwestern in a different building, so don't come here for it. It's in the Robert H. Lurie Medical Research Center. We're going to be having a World AIDS Day Symposium, and some of the information is up on the slide. If you go to the Impact Program website, which is impactprogram.org, you can see the details for the conference and how to submit an abstract. And it's going to include symposiums highlighting new HIV research advances. There'll be a reception following to raise awareness. And the fact that we'll be having an event in April, a conference here in Chicago focused on a cure for HIV. So keep that on your calendar and check out the Impact Program website for more information. Let me now introduce Eric Conley. He's the Vice President of Operations at Northwestern Memorial Hospital. The Northwestern Memorial Hospital is one of our platinum sponsors. I just want to invite him up to make a few comments.
Good morning. My name is Eric Conley. I'm the Vice President of Operations here at Northwestern Memorial Hospital. And it is absolutely my privilege to welcome you to Impact's 2013 LGBT Health and Wellness Conference here at Northwestern Memorial. I want to thank the Impact Program and the Center on Halsted for bringing us together today to learn about their current research in LGBTQ health and to exchange ideas and network. It is an honor to have here Dr. Tabak and Dr. Bogdan here with us today as they share their new and multifaceted health issues emerging in the LGBT community. Here at Northwestern Memorial Hospital, we are proud to be a designated leader in LGBT healthcare equality by the Human Rights Council, promoting equitable and inclusive care for lesbian, gay, bisexual, and transgender patients and their families. We believe in treating patients in an environment that is equitable, inclusive. Inclusivity is fundamental to our patients' first mission. Non-discrimination policies for LGBT patients and employees, equal visitation for same-sex partners, LGBTQ health education for staff, same-sex domestic partner benefits, Northwestern Chicago Out Network, a networking group for support and encouragement of LGBT faculty, staff, students, and fellow residents. These are all core organizations that people to our mission here at Northwestern Medicine. We're pleased to have all of you here. It's a wonderful turnout here today for this conference as we explore new and complex health issues currently emerging in the LGBTQ community. It is now my pleasure to introduce Dr. Claudia Mosier, the Director of Mental Health, Center on Halsted.
Good morning, everybody. It is such a delight to see so many people here at this conference. The advancing of the research for LGBTQ folks is something that's critically important for our society, and to see so many people here that have that interest and have the knowledge. Please talk to each other and learn from each other and make connections with each other so that you can help move everything forward as the LGBTQ community advances. And at the Center on Halsted, that we are a community center. Who's not been to the Center on Halsted here today? So there's been a few folks, but most people, okay, good. The Center on Halsted started out as Horizons, Gay Horizons, and that was in 1973. And everything that had the word gay on it back in 1973, let me tell you, was a really, really, really big deal. The Horizons started as a place for people to meet and as a resource clearinghouse. And for the past 7 years, we have been the Center on Halsted, and we've been at our building that's on Halsted Street. At our community center, our job is to advance and secure the health and well-being for the LGBTQ community. We do that by welcoming everybody to our community center. About 1,000 people a day come through our doors. And we have programming and space for people from little tiny toddlers in our children's area to our senior programs and our new senior housing building that will be opening up next year. So for the youth, we have a youth program that works with youth to the age of 25. We have many cultural events that happen constantly in the Center on Halsted, and we have our safe space where we have lunches and meals and tango lessons and movies and discussion groups for our seniors. And I want to talk for a moment about my pride and joy, which is the mental health department at the Center on Halsted. We serve about 500 clients a year at the Center on Halsted, and we have a wide range of therapists who work with us to serve our clients. So because we believe in the diversity of types of therapists, the unifying factors is that our therapists are all strength-based, they're all LGBTQ competent, and they're all trauma-informed. We do groups, individuals therapy, we do couples, and we do family therapy. We have volunteer contractual therapists, so I always do a plug for people who might want to become a volunteer We have a small mental health staff, and we have a wonderful team of students. We have 10 students all together. And speaking of that, a bunch of mental health staff and students are around the room. And I just wanted to give you all my personal thanks for all of the things that you do every day to make the mental health department center on Halsted a shining example of how to work with LGBTQ folks, and specifically with the work that you do at making this conference happen today. I don't know if you all have put a conference together before, but it's an anxiety, at least for me, and your thank you to me, for producing the process. Are there going to be enough sponsors? Are there going to be enough people? Is the room the right size? I mean, there's so many different factors that come to it. So when we're finally here today, and the conference is happening, and we've got such a great group of presenters, and it's just a marvelous thing, and I'm richly excited by it. My job today is to introduce Dr. Lawrence Tabak. Dr. Tabak is going to be talking about LGBTQI health research at the National Institutes of Health. But before he does that, I'd like to just give you a little bit about his background. Dr. Tabak was appointed as the Principal Deputy Director of NIH in August of 2010. Previously, he served as Acting Principal Deputy Director of the National Institute of Health from November 13th of 2008 through 2009. He is named as the Director of National Institute of Dental and Craniofacial Research in September of 2000, and he held that post through 2010. Prior to joining the NIH, Dr. Tabak served as a Senior Associate Dean for Research and Professor of Dentistry and Biochemistry and Biophysics in the School of Medicine and Dentistry at the University of Rochester, New York. He's a former NIH merit recipient himself, and he's received several honors and awards for his work, including being elected as a member of the Institute of Medicine of the National Academies. He's also received teaching awards for his work with both graduate and medical students. So Dr. Tabak, come up.
Thank you and good morning, everybody. It's really a great pleasure to be here. So I need to thank, of course, the organizers. So if this is really the first conference you've done, you're in trouble because if you do it really well the first time, they come back to you again and again. And a thank you to my hosts today, really Brian, George Green, and Julie. And they have worked very carefully with Rashad Alexander at NIH, and myself, and I do appreciate that interaction. And really, I'm glad to be here to speak with you, but unlike most NIH talks, the more important part of this is going to be the listening. So I will give you a presentation, but I'm actually going to listen to what you have to say. And I hope that we can, including this talk and certainly during the listening session, formal listening session, that none of you will be bashful. Now I understand there are a few plants in the audience, folks who are NIH-funded investigators, and they know the game, and they will not be bashful. You should follow their lead. So I hope you're able to. So what I'm going to do this morning is cover these few topics. I know that the group is heterogeneous. Some of you are NIH-funded investigators. Some of you probably don't even know what NIH is. And so I'm going to try and hit the sweet spot and to give you just a little background about NIH. Then speak to you a bit about the Institute of Medicine report, which has had, I think, a very positive influence on activities at NIH. Tell you about the NIH LGBT Coordinating Committee, and briefly highlight the research portfolio analysis that was done for 2010. Fast forward to the goals of the current year. So you should know that the federal government is unusual in many ways, but budgetarily, we're in fiscal year 14 now. Your calendar still says 2013, but October 1st, we began 2014 in terms of fiscal year. So this 2013, 2014 goals, that's real time for us. How we coordinate with the Department of Health and Human Services, the National Institutes of Health, is part of the Department of Health and Human Services. And then finally, talk a little bit about some of the resources that may be available to you. The photograph is that of Building 1. This is where the NIH Director, Francis Collins, and I hang out together with our staff. And it's a nice building. It's where Roosevelt actually launched NIH many years ago, actually from that balcony. There's a little plaque which we had to restore so that nobody could read it. But now it's back restored. And so if you're ever on the NIH campus or in Bethesda or in Washington, D.C., you should pick us up. And everybody knows where that building is. So NIH 101. So NIH is the largest funder of biomedical research in the world. And we do so by supporting work in pursuit of fundamental knowledge about the nature and behavior of living systems. But the second part of this is very important, and the application of that knowledge to extend health life and reduce illness and disabilities. In other words, we are responsible for supporting fundamental and basic research, but we are also obligated to translate that knowledge into tangibles that help patients, keep us all healthy, free of disease. The National Institutes, plural, of Health is we call it a decentralized organization. It consists of 27 institutes and centers. And we put an Office of the Director, OD, in the center there. Now, this is illusionary. And in fact, when institute and center directors do this talk, they don't even have the Office of the Director on the slide. If there's anybody from central administration, go. And each of the institutes and centers have these odd-sounding acronyms. So NCI is the National Cancer Institute. It's the largest institute, budgeted just under $5 million a year. And then, I guess the smallest one is the Fogarty International Center, and everything in between. Now, most of these institutes and centers have both extramural programs, that is, funding to institutions around the country, like here, but also support a small amount of research intramural on the NIH campus. Only the National Institute of General Medical Sciences, which oddly enough really funds basic research, and the Fogarty International Center, they only have extramural programs. They do not have and then these three units have no funding authority, they're more service organizations. The one that the NIH investigators know well is the Center for Scientific Review, which actually does peer review of about 70% of all the applications that NIH receives. Now, the fiscal year 2013, which has just ended, our full year continuing resolution budget is $29.1 billion. You all know about sequester and the impact that that has on NIH. Overwhelmingly, this resource set is spent outside of the NIH. 84% is used to support some 300,000 people across the country in institutions like this. About 10% is spent at NIH to support intramural research programs, including the NIH Clinical Center, which is the largest exclusively research hospital in the world. Every patient in the NIH Clinical Center is on a research protocol. So there's no ordinary care you would find in a university hospital. Every single patient is on a research protocol. And the remainder, of course, is just to keep the place. So there's good news and bad news in this slide. It displays the NIH appropriated dollars in blue. And you can see we went through this remarkable period of the so-called NIH doubling. And that was a heady time in science. People were having great dreams, and deans, chancellors bragged about how many trains they had in their parking lots of new buildings seemingly came up overnight. And then, of course, we leveled off in the mid-2000s. And little bump up here was a miracle called Recover That. We received $10 billion extra dollars. And then, of course, going from 2012 to 2013, we actually had a significant drop of about $1.5 billion in the effective budget, something that is destined to hit again if nothing is done to address this. But the real concerning aspect of this slide are not the blue bars, because those are absolute dollars, but rather the yellow bars, which show you, using 1998 as the index here, the buying power that our budget allows. And so, as you will recall from your Economics 101 class, inflation tends to eat away at things, particularly in the healthcare space. You all know that healthcare costs dramatically increase, the cost of medications increase disproportionately to inflation in general. And so as a result, we have been effectively undoubled, and we're back down to where we were about 2000. Now, the conundrum is we have this constraint on our budget, both in absolute, but more importantly, in terms of buying power, at a time when the scientific opportunities have never been more dramatic, have never been more spectacular, at a time when we have more young people who are sort of thinking, should I go into biomedical research as a career? And this is the sort of sobering news that we have to present to. So it really is an odd time. Best of times, worst of times type. Now, when I was in academia, I had three bosses. Dean of the medical school, the vice president of health affairs, and my wife. Not necessarily in that order. Now, since coming to government service in 2000, I have many, many, many more bosses. Indeed, all of you are my bosses. Because in government, every voice has to count. And so we listen very carefully to the general public, patients and advocacy groups. Congress weighs in with their recommendations. We have many ad hoc advisors, both professional as well as laypersons. Industry will weigh in from their perspective. Each institute or center has a national advisory council of prominent scientists and lay people. The president and the administration weigh in on occasion. And of course, the scientists themselves. All of these people voice, all of these people need to listen to. I still have to listen to my wife's voice. So, just again, for those of you who are not familiar with the NIH process, and for those of you who are, my apologies, this is sort of old hat to me, but about 70% of the applications that NIH receives are the result of an idea that an individual investigator or a team of investigators have. They dream up the idea, they put together an application, they submit it. The remaining 30% come in response to funding opportunity announcements that various institutes and centers put out, saying that we have put aside some money to help support research in this particular area. Or, in the case where there's no money set aside, program announcement, which simply says that an institute or center is particularly interested in a given area. So as a new investigator, or as an aspiring investigator, you should be mindful of those funding opportunity announcements, both those where there's money set aside, as well as those which at least the institute or center is declaring a particular interest in that area of research. Now, regardless of how the application was generated, either an investigator initiated or in response to a funding opportunity announcement, they are all subjected to peer review by a scientific review panel. And so this is what these study sessions are about. These are scientists from around the country who come together to review all applications. The results of that review, which describe the scientific merit of the application, are then sent to the program officer of the relevant institute or center that oversees the portfolio that application, should it be funded, would be put into. Now, again, for those of you who are new to this game, rule 1, learn who your program officer is and contact them. It is not cheating. It is part of their job. There is some barrier that new investigators have to contacting their program officer. So if you are a new investigator contemplating sending in an application, you already have, and you don't know your program officer, by the end of the day, find out who it is, email them, and set up time to talk. The program officer then presents the application and its review to the Institute or Center's National Advisory Council, which then looks at the mechanics of the peer review to ensure that it was done properly, and then looks at the application in the context of all the other things that the Institute or Center are funding. Is this redundant work? Is this novel work? Is this part of one of the Institute's stated priorities? In other words, is it in alignment or not? If it is, then there will be a positive recommendation, which goes to the Institute or Center director, and then he or she makes the final decision. That gets fed back to Congress, and then yearly we have to justify to Congress what we did with all that money and why they should give us some more. So that's the cycle that occurs each year. In 2009, the NIH commissioned the Institute of Medicine to do a report on the health of lesbian, gay, bisexual, and transgender people. And the report was actually published in 2011. It represents the first ever comprehensive report on LGBT health. Within it, there is an extensive literature review of the existing research on LGBT health. And if you're not familiar with this report, I certainly would recommend it to you. Go to the IOM website and see how to access it, read it online. So, just to briefly summarize the report, they point to the dearth of national level health data. Those of you in this field just nod your head and go, well, tell me something I didn't know. And among the research challenges are the diversity among and within LGBTI population. There are methodological limitations, and then there are a whole myriad of concerns related to either self-identification or privacy. This report called for an IOM State of the Science report and for information on the existing NIH LGBT research portfolio. recommendations, we asked NIH to implement research agenda. They requested that we collect sexual orientation and gender identity data using federally funded surveys, electronic health records. We asked them to develop standardized gender identity measures. We asked them to support methodological research related to LGBT. Next, we create a comprehensive research training approach to strengthen LGBT health. And finally, we encourage grant applications to address explicitly the exclusion or inclusion of sexual and gender minorities. In response to the IOM report, NIH formed the NIH LGBT Coordinating Committee, and in 2010 they issued a portfolio analysis. And the charge given to this committee was to develop and coordinate potential research and training activities related to LGBT health, research gaps and opportunities. Now remember, I shared with you that display of all the institutes and centers of NIH. We've got 27 organizations, 24 of which receive separate appropriations from the Congress. So they really are very distributed in their organizational function. They also wanted us to assess relevant past and ongoing activities across NIH, and then finally, to develop and recommend strategies to track and monitor NIH research initiatives and progress in LGBT research. In other words, a fundamental scientific principle. You can't measure it. Nothing's going to get done. So the analysis validated IOM study findings. We discovered that LGBT research was distributed across 13 different institute centers and women offices. The research areas were largely behavioral and social science, mental health, and drug abuse, particularly as it relates to HIV. This pie chart depicts the level and percentage of support for LGBT projects. Not surprisingly, this is dominated by NIMH, National Institute of Health, NIDA, National Institute of Drug Abuse, NICHD, National Institute of Child Health and Development, and NIAID, National Institute of Allergy and Infectious Diseases. With additional investments made by the other institutes and centers displayed. We try to classify the different projects. Now, again, for the mathematicians in the audience, it's going to add up to more than 100% because we double count this. Certain things can fall in multiple buckets. And so again, reflecting what I said earlier, a great deal of projects related to behavioral social science, I think understandably dominated by research in HIV/AIDS, mental health, and sexually transmitted diseases, and substance abuse, but again, largely related to HIV/AIDS. And rather low levels, in the view of many, of research related to violence, suicide, depression, aging. And so, to summarize the analysis report findings of the NIH portfolio, as you've seen, there's relatively little research focused on particular health and distinct LGBT subgroups. And so, as a result, there are many opportunities to create or further develop both research and training programs. And examples here are just listed. I'm sure you can think of many others. The methodological approaches, data collection needs do remain a challenge. It'd be very interesting to hear from here how we might overcome some of these challenges. Additional findings, we need a series of improvements. First, we need to enhance the cultural competence amongst our clinicians, researchers, and staff. The communication between NIH and the relevant advocacy and research communities has to be increased. In general, we need to include LGBTI populations in these funding opportunities. And there are a number of opportunities for trans-agency collaborations or activities, including what has now become an NIH June Pride event, as well as cultural competency education and training opportunities. The coordinating committee was behind the reissuance of funding opportunity announcement on LGBTI health, and the link is displayed there. We also provided support for the CDC, Center for Disease Control, a National Center for Health Statistics Development of sexual orientation questions for the various national health surveys. And so the NSFG now includes questions on sexual identity, attraction, and behavior. And as of January 2013, NHIS now includes questions on sexual orientation. And NIH also co-sponsored a workshop on sexual orientation and gender identity collection in EHRs, electronic health. What about the current goals of this coordinating committee? In 2013, we sort of recharged the group to provide a forum for discussing diverse health issues for the LGBTI communities and to serve the catalytic role in developing additional LGBTI research training initiatives. And so among these, to facilitate and coordinate activities, not only across NIH, but to reach out to other federal agencies, to develop potential research and training activities, to develop and recommend strategies to track and monitor these activities, and importantly, monitor the progress. And then report the NIH activities to the Department of Health and Human Services. We have already done outreach to the NIH community and we continue to do so, and we've had a series of opportunities to have outreach to extramural stakeholders. We had several listening sessions beginning in June 27th with Dr. Collins. A large number of topics were covered during that listening session, including issues related to training, transgender health, research. We released a request for information on LGBTI health research priorities. So when the government wants to get input from a broad range of individuals, we put out a formal notice asking for information. This was released in late June and just closed. I hope some of you had the opportunity to respond to it. The response has been robust, but obviously it had just closed, so I don't have any metrics. We have attended a series of professional conferences, and they are listed there. And in addition, we've also participated in a number of federal. Developing an annual LGBTI health research symposium. We're going to develop formally a health research strategic plan, and then we will do, based on 2012 numbers, we will update that portfolio analysis that I shared earlier in 2010 in the hopes of seeing what the trend lines are. And so this is something that we're not going to have to figure out and repeat. So we can see what trends or what those are remaining the same. Now, we've gotten all types of feedback, and I wanted to share some of that with you, both to see if it resonates with you as a group, but also to give you a sense of what others in the communities are saying. We heard loud and clear from trainees interested in LGBTI health research. But we've also heard from trainees who are interested in research who themselves identify as LGBTI. And they're different kinds of issues. Sometimes it's one and the same person, but not always. And there was a very strong sense that we need to do things to catalyze and enhance the opportunities to support trainees in both of these categories. We've also heard strongly that we need language that welcomes LGBTI research concerns and invites LGBTI researchers to apply for funding. Now, as part of this conversation, we also learned that not all sexual and gender minorities identify as LGBTI. And we heard very interesting poignant discussion of this from a two-spirit, which is by way of example. There's a need for healthcare and care research that's culturally sensitive, welcoming to sexual and gender minority patients. The Agency for Health Care Research Equality, AHRQ, which is a sister agency within the Department of Health and Human Services, as is the Health Resources and Services Administration. First, you've heard about this, getting a training grant. The major roles in funding the research that informs healthcare practices. So that our sister agencies do that type of work. We focus on disease and health mechanisms. We do support some research that informs medical practice, but it tends to not be quite as proximal to what HRSA and AHRQ might do. But all of the sister agencies do talk to one another. Now, I know this seems odd, but we actually do. And as a result, it allows us to address issues more effectively. So that leads us to coordinating health and services. There is a Department of Health and Human Services LGBT Coordinating Committee. This was formed in 2010 by Secretary of Health and Human Services, Catherine Sebelius, to identify steps the department can take to improve the health and well-being of individuals and their families. This includes representatives from across HHS represented there are a number of NIH resources, and I know that people's eyes glaze over when you say, go to the website or click on this link and so forth. Which is why earlier in the talk I said, know who your program officer is, because he or she is a human being that you should be willing to reach out to. They often can direct you to things that you are particularly interested in. But these general links might be of value to you. The NIH guide for grants and contracts, you can set it up so that you get it weekly, automatically. That's something that if you are interested in writing an application for NIH support that you want to be aware of, because it does give you whatever is new in real time. Regional seminars that NIH conducts, sort of how-to, they are done periodically throughout the country. If you have an opportunity to attend one of them, I would certainly urge you to do that, because they are worth it for a while in terms of practical advice that you will receive. And then, if I hadn't said it before, okay, so with that, I will stop and hope there are a few comments questions. If some of you have a late breaking idea, this is usually what happens, going back to your office after these types of programs, oh, what about this? Please contact us at this email address. It is being monitored, actually by Rashad. And any input or ideas that you have, or any things that, for whatever reason, you want to say out loud here today, that mail will have to say. So, thank you for your attention. I'd be happy to answer. This is where you have to ask questions. Otherwise, I will start talking about the Krebs cycle. Hands go up. Yes, please.
Thank you. I appreciate everything, and I'm doing to support this line of research. I just wonder if there are any efforts to educate and train reviewers so that there are adequate reviewers on study sectors.
Yeah, so I'm going to repeat the question because we have a webcast and in case those of you this. So the question was, is there any effort to train potential reviewers of this type of research? So we have not done this formally, but it is something that needs to be done. The first step, however, is for groups like this to identify individuals who you feel would make great reviewers of this type of research. Because they're the ones who can form a core that we can build upon and around. Now, I appreciate that we have this odd conundrum with NIH review. Usually, you don't get to review until you have an NIH grant. Yet, you learn a lot by reviewing, and it helps you learn to write NIH grants. So there's this circle. So for those of you who already have an NIH grant, fine. You're already in, so you should just make yourself known, and you can send me your name, because we are always trying to find individuals who will strengthen our review team. But for those of you who have not yet had your first NIH grant, we have something called an early career review program. And what this is designed to do is to give individuals who are at an earlier stage in their career might not yet have their first R01, but let's say you had a career development award, or you've been a co-investigator on a senior person's career, and so forth. And what we do is we invite you to participate as an ad hoc reviewer. So you get to come to a study session meeting. You have a reduced load of grants. We do this for all ad hoc reviewers generally who are new. We do a reduced load of grants. Like all ad hoc reviewers, if you do a great job, you will be invited back. And if you don't do a great job, you will not be invited back. But what it does is it gives you some insights into how the process works. And in this case, it also would enable us to identify additional persons with the requisite expertise to begin to form a core group. So I thank you for raising that question. And if you have ideas, either self-nominations or if you have ideas of colleagues who you think would make great reviewers and who are culturally competent, sensitive to these areas,